This presentation is adapted from Pulmonary, Sleep, Cardiology, and Critical Care Academy, an online CME-accredited course for advanced practitioners and physicians. My name is Dr. Peter Sloan, and I am one of the course directors. I would like to introduce our speaker, Dr. David Weissman, who will demonstrate A lines and B lines on thoracic ultrasound.
When performing lung ultrasound, it's important to note what we are actually seeing on the screen is artifact. It is the repetition and consistency of the artifact that is very useful for us when doing lung ultrasound, because once we know what normal looks like, we will be able to easily identify when something is abnormal. So first we're going to look at what a normal lung looks like under ultrasound. So here we are using a high frequency probe as delineated by this linear marking. Remember, we are in the traditional computer mode. This could be in abdominal mode, or this can be in the lung ultrasound mode, and this is where the typical radiological computer marker would be. So our probe is pointing to the patient's head as we are transversing over the ribs and intercostal spaces in a perpendicular fashion. There are several key landmarks to note from this image here. First, we are seeing the ribs. The ribs are a thin line of brightness, hyperechoic. Remember, they are very dense structures, bones, so it is very reflective. And there is quite a bit of acoustic shadowing because of the bone. They would not be able to penetrate through the ultrasound beams, and therefore we get acoustic shadowing thereafter. In between the ribs, we have the very bright pleura. And the pleura will be seen in a moment moving back and forth as the visceral and the parietal surfaces move over each other as the patient breathes in that very small space. And it's actually a beautiful movement described in various different ways as ants marching in a row or glistening. And then as the ultrasound beams dive through, some will actually be reflected off the pleura, some will dive down through deeper layers of the lung and get reflected back. And the reflection that we see here are called A lines, and these are reflection artifacts from the highly reflective parietal pleura. So as we move forward, recall that the artificial repetitions of the pleural line will be displayed in regular intervals. In fact, you can march them out directly from the skin to the pleura, and they'll be repeated in the exact centimeters for each individual patient, which is really neat. The ribs and then their rib shadows, as seen here, and the pleural surface and the pleural line, as denoted by the arrows, and the A lines. So A lines are normal reverberation artifact from the highly reflective parietal pleura. And here is the real-time movement of the pleura. You can see the beautiful glistening effect of the visceral and parietal surfaces rubbing over each other as the patient breathes, and it moves back and forth in a very nice fashion. And then we have distinct A lines that are seen here as they are reflective artifacts of the highly reflective parietal pleura. In this cartoon image, let's review the sequence of events that cause the reverberation artifact seen in lung ultrasound. For orientation purposes here is the linear high frequency probe. You will notice that we are perpendicular to the ribs in between the intercostal spaces. We have the skin line pictured here. Here we have the gel in between and the pleura. These surfaces have a lot of acoustic impedance. As the ultrasound waves bounce back and forth, let's watch what happens. What we're seeing here is the reverberation artifact that occurs with highly reflective surfaces and the interplay with large differences in acoustic impedance. There is a very large acoustic impedance between the skin and the pleural surface, which is extremely reflective. In this case of lung ultrasound, the highly reflective pleural surface and the skin transducer interface create this reverberation artifact that manifests in the A lines that we see below. Once again, visualized here is the normal lung A-line pattern, just to identify structures here. Here we have our linear probe, denoted by this thin line. We see that the computer marker is in the standard radiological mode. This could be in either abdominal or lung ultrasound. And the purpose for that is to set the right frequency that really brings out the A lines. Here we see our rib, and we have acoustic shadowing on both sides. We see our pleura. Again, this is the visceral and the parietal surfaces moving back and forth as the patient breathes. And as we reviewed before, the reflective phenomenon of the sonographic waves diving through and bouncing back and forth off the reflective pleura create the artificial A lines that we're seeing in front of us. And once again, we can march those out directly from skin surface to pleura, and each one of these spaces in between will be the exact same centimeters in between, and that is normal lung ultrasound. The first pathological finding we will be discussing in lung ultrasound are B lines. You will notice these B lines are vertical lines that stem from the pleura surface all the way down to the bottom of the screen. You see several of them listed in this particular example. Again, these are B lines that extend from the pleura all the way vertically to the bottom of the screen. B lines are seen in many different conditions when they are diffuse, meaning in multiple different quadrants. Most commonly, base rate, it would be pulmonary edema is the most common cause of diffuse B lines. However, this can also be seen in diffuse interstitial pneumonitis, such as interstitial lung disease or ARDS. When the B lines are seen in specific focal areas, specific focal quadrants, that may be indicative of a focal pneumonia, atelectasis, lung contusion, pulmonary infarct, or malignancy. Once again, here is that example of movement of the B lines as the patient breathes. You can see the vertical lines follow the pleura, stemming again from the pleura all the way down to the bottom of the screen. Here we have several B lines seen in one image. You will notice that the pleura that we saw in previous examples is not nice and smooth and linear. Here it is broken up into many different components, almost ratted up or bites taken out of it. This is quite typical of what we'll see in a viral pneumonia or perhaps interstitial lung disease. This particular patient had COVID-19. Here is another example of B lines in lung ultrasound. It is very important to note that sometimes in the dependent areas of the lung, you may normally see 1 or 2 B lines. It is always abnormal to see 3 or more B lines, as we see in this lung field. Often B lines are also described as discrete or confluent. Discrete B lines, as seen here, have discrete markings, so you can individually see one B line from the other. Often you will have patients who will have confluent B lines, where the B lines merge into one uniform large B line.
If you'd like to learn more, please visit our educational center at pulmonaryandsleepacademy.com, where we have 70 hours of self-paced online CME-accredited courses covering pulmonary, sleep, cardiology, and critical care medicine. Please enjoy more of our short visits on our PSA YouTube channel. You can purchase our full courses with an exclusive 10% discount code using YouTube10.